Resting 12-lead ECG procedures. Before getting started on the lead placements, we will begin with reviewing anatomical landmarks. The clavicles are the two bones that are attached to the acromion and the manubrium. The jugular notch is at the top of the manubrium, which is in the center of the pectoralis, where the clavicles attach. Below the jugular notch, where the manubrium and sternum meet, is known as the angle of Lewis. Immediately to the right of the angle of Lewis is the second intercostal space. The intercostal spaces are numbered sequentially from top to bottom, so this second space will be a point of reference later on. Lead placements. 3-lead ECG placement. Step 1. Shave or clip hair from electrode sites if necessary. Step 2. Thoroughly clear skin and lightly rub dry. Use the isopropyl alcohol or special skin preparation pads. Be sure to clean skin well and rough it up with skin prep pads in order to minimize artifact or noise. To minimize artifact during exercise, you might need to include small stress loops in each lead wire and tape the loop to the subject's skin. Step 3. Apply electrodes to the subject in the standard configuration for limb leads. Follow these instructions for locating the appropriate anatomical locations. LA, left arm, just below the left mid-clavicle, just above the pectoralis muscle, medial to the anterior deltoid. Lead color will be black. RA, right arm, just below the mid-right clavicle, just above the pectoralis muscle, medial to the anterior deltoid. The lead color will be white. LL, left leg, between the left oblique and rectus abdominis, level with the umbilicus. Lead will be red colored. RL, right leg, between the right oblique and rectus abdominis, level with the umbilicus. Lead will be green colored. A common saying for 3-lead ECG placements are smoke over fire and clouds over grass. 12-lead ECG placement. Follow normal 3-lead application as stated previously. Precordial or chest leads. Locating the V1 position or fourth intercostal space is critically important because it is a reference point for locating the placement of the remaining VC leads. To locate the V1/C1 position, place your finger at the jugular notch, the notch at the top of the manubrium. Step 2. Move your finger slowly downward about 1.5 inches or 3.8 centimeters until you feel a slight horizontal ridge or elevation. This is the angle of Lewis, where the manubrium joins the body of the sternum. Step 3. Locate the second intercostal space by moving your finger to the patient's right, lateral to the just below the angle of Lewis. Step 4. Move your finger down 2 more intercostal spaces to the fourth intercostal space, which is the V1/C1 position. Be sure to place the lead over the intercostal space and not over the ribs above and below the intercostal space. Step 5. Continue locating other positions from V1. Some important considerations. When placing electrodes on female patients, always place leads V3 to V6 under the breast rather than on the breast. Use direction with female subjects and maintain a professional approach at all times. Women may want to find the electrode site themselves or with the aid of another female lab mate. To locate all other lead placement sites, V1 is on the right side sternal border on the fourth intercostal space. V2 is on the left side sternal border on the fourth intercostal space. V4 is on the midclavicular line in the fifth intercostal space. V3 is at the midpoint of a straight line between V2 and V4. V5 is on the anterior axillary line horizontal to V4. V6 is on the mid-axillary line horizontal to V4 and V5. Be sure to put V1, V2, and V4 in the spaces between the ribs, not on the ribs. When connecting the cables to the leads, ensure that the cables are not too taut and that they are laid down flat on the table or suspended as to avoid any interference from affecting the ECG reading.
Now that we've explained how to attach the leads to our subject, we will review how to actually receive and analyze the ECG data. Since this video is specifically about a resting ECG, it is important that the patient has had sufficient time to lay down and relax, at least 5 minutes, so the heart can adapt to a lower level of activity. We do this because our goal is to analyze the activity of the heart during a resting state, not during exercise or post-exercise. The cables that we attach to the leads in the previous section of this video will all converge to a plug that attaches into the NASIF cardio card unit. This will attach to the PC via USB cable and transfer the data into the actual ECG software. To view this data, open the CardioCare software from the desktop. Before beginning, make sure to enter the patient information. You can do this by clicking File and then clicking Preload Patient Demographics and then enter the required information for your patient or client. This includes things like their name, age, gender, and date of birth. Additionally, before beginning, you want to make sure that you click the lead drop-down menu and make sure the 12 lead option is selected. After this, you may simply click the ECG button at the top of the screen to begin receiving data on the PC. Once you have done this, you can begin to analyze the data on the screen. Make sure that there's a clean reading with no noise and then print the ECG strip for later evaluation. Now that we have the data to interpret, it is important to remember that every ECG will be different depending on the individual. So interpretation is dependent on precise measurements of time and amplitude of the ECG data. The boxes on an ECG are equivalent to both time and amplitude. A small box is 1 millimeter and 0.04 seconds, while a large box is 5 millimeters and 0.2 seconds. ECG, electrocardiograph, and is a representation of the electrical activity of the heart, is made up of several waves and segments. The P wave represents the depolarization of both atria. This depolarization spreads from the sinoatrial node to the atrioventricular node. The QRS complex is a large wave that shows the rapid and large depolarization of the right and left ventricles. Lastly, the T wave represents the repolarization of these ventricles. The PR interval is the time from the beginning of the P wave to the beginning of the QRS complex. And the ST segment, which is something we will focus on a lot when reading a resting ECG, is the segment between the QRS complex and the T wave. The J point is where the QRS complex ends and the ST segment begins. This is important because this is where you will start to look for changes in the ST segment later on. This is what a normal ECG would look like. A normal P wave will last less than 0.12 seconds. A normal PR interval is between 0.12 and 0.2 seconds, or is less than one large box. In the reading for our subject, you can see that the P wave is smaller than 3 small boxes. This means that the time of the P wave is smaller than 0.12 seconds, making this a normal value. You can also see that the PR interval is somewhere between 4 and 5 boxes, making it between 0.16 and 0.2 seconds long, again falling within the normal value. A normal QRS interval is less than 0.12 seconds or less than 3 small boxes. A normal QT interval is less than half of an R2R interval and varies with heart rate. A QTC, or corrected QT interval, is normally between 0.33 and 0.47 seconds. A corrected QT interval means that it has been changed to 60 beats per minute for comparison purposes. One trick for calculating heart rate is counting the big boxes between R waves in the following method. Starting at the peak of an R wave, the first box would be 300 beats per minute. The next is 150, followed by 100, 75, 60, and finally 50. The number you choose is the one where the next R wave peak lies. This simple way allows you to calculate heart rate in beats per minute. Since we do have all 12 leads, comparisons between the individual leads can give us information about abnormalities of the heart. The first one we're going to talk about is axis deviation, which gives us information about the direction of the electrical activity in the heart. So the different axis, or the determining vector quadrant, can be interpreted on the EKG by looking at the following things. With normal activity, the QRS wave is going to be positive in both lead 1 and the AVF lead. By zooming into our ECG, you can see that in lead 1, the QRS wave is going in a positive or upward direction, and in the AVF wave, it is also going in a positive direction. Extreme right axis deviation can be seen when lead 1 and the AVF lead both show a negative QRS wave. Right axis deviation that may not be as extreme will still be seen when lead 1 has a negative QRS wave, but the AVF has a positive QRS wave. Left axis deviation can be seen when lead 1 is positive and AVF has the negative QRS wave. We could also identify hypertrophy by looking at these leads, which is the thickening of the ventricle walls that occurs due to things like high blood pressure or heart conditions where the heart is asked to work harder than usual. Right ventricle hypertrophy can be seen with R waves in V1 that have smaller R waves in V2 through V6, S waves that persist in V5 and V6, and the presence of a right axis deviation with a wide QRS wave also indicates right ventricle hypertrophy. Again, if you look at our ECG example, you could see that things are relatively normal. In V1, the R waves are much smaller than the R waves that are present in V2 through V6. Also looking at V5 and V6, you could see that no S waves are present, indicating that this is a normal ECG and that there is no hypertrophy. Left ventricular hypertrophy can be identified by a S wave in V1 accompanied by a large R wave in V5 greater than 35 millimeters. And similar to the right ventricle, a left axis deviation with a wide QRS wave is also an indicator of left ventricular hypertrophy. Once again, our ECG looks very normal. While there is an S wave in V1, the R wave in V5 is about 15 to 17 millimeters and nowhere near the 35 millimeters that would indicate ventricular hypertrophy. A myocardial infarction can also be identified on the resting ECG. The absence of Q waves at rest are indicative of a myocardial infarction, or changes in the ST segment, including an elevated ST segment with a significant Q wave that would point to an acute myocardial infarction or a persistent ST depression. Other important heart conditions like ischemia, which is a lack of oxygen to the myocardial tissue, or ectopy, which is an abnormality in cardiac rhythm, are both identifiable on an ECG, but only during exercise and not during rest.